Welcome to UOA On Demand. My name is Dr. Robert Pannullo, and I'm an interventional physiatrist and pain management specialist, and I'm joined today by my fellow interventional physiatrist and pain management specialist, Dr. Pavli Demian and Dr. Tony George. Welcome, gentlemen.
Hello.
Thank you. Hi.
We're here tonight to discuss what we do here at UOA, and that is physiatry. I think the first question to ask, what is a physiatrist? Which in some cases in the Midwest or Western states, they call it a physiatrist, but both will apply. We are doctors who have training in physical medicine and rehabilitation. That's quite a few syllables, so usually it's shortened to physiatrist. I would first just define that by saying we are musculoskeletal specialists, but we're not just limited to the musculoskeletal system. And us three, we have special interest in pain management, as well as board certification and training in doing non-operative procedures. So I'd first open up the discussion by asking Dr. Demian, what is physiatry to you?
So I think physiatry to me really comes down to being a function doctor. How do we get our patients to function as best as they can? They may have something that hurts, something that limits their ability, whether it's a range of motion deficit, limits their ability to do what they want to do. And to me, it's first diagnosing the cause of that, and two, implementing a plan that'll restore that function to our patients.
I agree. How about you, Dr. George?
So yeah, I agree with Pavli when he stated that the primary role of a physiatrist is to look at function. And one thing I'd add to that is function and the goals of function. And the goals of function may vary between individuals. Like you've heard the term restoring function. That's a term we commonly use, and that may change based on the patient that we deal with. Restoring function means that, for example, if I am an individual, I will be carrying out my daily activities, self-care activities with ease, carrying out routine activities without any problems. And let's say one day there's a setback and there's an accident, and then as an individual, I cannot function anymore. So that has taken me from my baseline of being able to function normally to a new state where I'm not able to function at all. So the goal of physiatrist would be to restore me from that new state back to my baseline where I once was. Now, another goal of physiatry would be to optimize function, which is a little different. That means I would think about athletes, for example, high performance athletes or individuals that are in sports. For them, their goal may be to optimize, to take it really from what an individual functionality is to optimize it to the best they can in their sport activities. And other times, the goal of a physiatrist would be to maintain a person's function. Many times, the patients we see in our practice, they're patients that have a function, but it might be impaired to some degree because of chronic injury. So when they come to see us, we may offer medications, we may offer injections, but the ultimate goal being to maintain them at the level of function to the best we can. So different goals, but in the end, I agree with what Pavli is saying. In the end, it is function, but the goals may be different based on the individuals that we deal with.
I remember years ago, too many, in fact, when I interviewed for my first question when I interviewed was, why do you want to be a physiatrist? And I quoted a famous physician who had said that our job is to restore and make whole all that bad fortune has taken away. Not so much that it would delight the eye, but to buoy up the spirit and to help the mind of the afflicted. I agree that we are to restore function, we're to maximize independence, and to get people back into the game of life again. We may not be able to restore your fastball that you had when you were younger, but at least we can get you back into the game and functioning better. I would add that we have special interest in pain management because so many conditions, especially ones encountered in an orthopedic group like this one, is to deal with pain. And we have special training in doing such procedures. So I would ask Dr. George, what kind of training do you have, and what kind of conditions do you see?
So my training was primarily I did my training in physical medicine rehab, and then I did a fellowship actually with the orthopedic department at UMass. So I got to see facets of pain management from an orthopedic perspective, and I brought that to my practice when I began after I finished my fellowship. Some of the common conditions we see, I see myself as kind of as an orthopedic, non-operative orthopedic specialist. So we don't manage the acute trauma, orthopedic trauma issues, but any of the elective orthopedic cases that come, I funnel through I look at those cases and I decide if they need physical therapy, if they need injections, or do they need surgery. So musculoskeletal orthopedic issues that don't need immediate attention, immediate acute attention, and are elective, those are good patients that would benefit from a physiatry assessment.
Good. Dr. Demian, do you have anything to add to that?
Yeah, I think one of the other facets of our training is diagnostics. So we work hand in hand with our other specialties in orthopedics to kind of help in diagnosis. Is, you know, what level of the nerve is injured, or when that can be done through things like electrodiagnostic or EMG testing, through different nerve blockades or injections, which will temporarily and diagnostically numb certain spots that may be causing our patients pain. And so by being able to hone that, it helps to really enhance the treatments that can be provided, not just by ourselves, but with our orthopedic colleagues as well.
No, I agree. And Dr. George, would you be able to comment on any kind of specific procedures that you do in relationship to those painful conditions that you treat?
So a common painful condition we see in our office is back pain and sciatic pain. So pain and pain that goes into the leg. So usually that, depending on the population, if depending on who is coming to see me, if it's a young adult or if it is an older aged individual, the source of the or the cause of that her sciatic pain may be different. For a young adult, it most likely would be from a disc herniation, from either trauma. From an older individual, it could be from stenosis, and they could also get back pain and leg pain. So common treatment we provide for these patients from an interventional standpoint, we do one thing, that is an injection called an epidural injection. But prior to that, even before deciding on an injection, we assess the patient and see, okay, what is their degree of pain? How impaired are they? Are they able to do their daily activities? How much is their quality of life impaired? And we decide based on that if we should first try conservative management with physical therapy and see if that will help them first. If that doesn't help them, then we decide if an injection would help alleviate their pain. So an epidural injection is done with fluoroscopic guidance. So we use X-ray guidance to help us look at the patient's back with an X-ray view, and then we target that area where we have identified on MRI view that there's a disc herniation, and we go to that level where we feel the nerve is irritated after we have examined the patient clinically in the office, and we do an injection to help alleviate the pain at that level where the nerve is affected.
Very good. And Dr. Demian, Dr. George has brought up doing an epidural, so therefore treating a painful condition like sciatica. But what if, let's say, the patient just had back pain and no leg pain? What might you do or treat?
So one of the other things we can treat is arthritis within the facet joints or some of the small joints in the low back. The low back has small joints. They're called facet joints. They are just like any other joint in the body, whether it's a knee or a hip. There's a small amount of cartilage, and with age and degenerative changes, that cartilage wears away and it creates an inflammatory situation within that joint that can be very painful. A lot of this is like that pain of getting up from a chair, or when you kind of that pain that forces you to lean forward. And we can address that pain with joint injections or nerve blocks, and potentially consideration for radiofrequency ablations or rhizotomies, which are essentially using a specialized needle to ablate those nerves, and in doing so, provide the patient meaningful, long-lasting relief.
And we would be able to provide such services for not just lower back pain, but also from the neck through the thoracic, through the lumbar region. And also, you've offered a service in regards to the knee. Let's say a person has chronic knee pain. Can you elaborate on that?
So we're able to offer several different types of procedures that can help patients with knee pain, depending on the cause of the knee pain. Things like a knee steroid injection or a knee viscosupplementation or gel injection. But also there's other possibilities for procedures for patients who, let's say, can't have those types of injections. There's things like called genicular nerve blocks. Genicular nerve blocks, it's just a fancy way of saying that those are the nerves that sense pain around the knee. And we can block them, and if need to, we can ablate them to potentially provide added benefit.
Dr. George, do you have anything to add to that, or any other painful conditions that you specifically treat?
Well, another painful condition we treat patients often when they fail epidural injections may also have surgery to address their back pain. And sometimes after surgery, so several years later, they could end up with persisting back pain and maybe even recurrence of the leg pain after surgery if scar tissue builds up, encases the nerve, and the nerve gets irritated, and now you have a new version of sciatica-like pain presenting to the patient. And in those cases, sometimes epidural injections fail, and they may not relieve the patient's pain. In those situations, there is another treatment that we all offer, which is spinal cord stimulation. And that is a way to, in a way, scrambling the pain that the patient feels by using electric wires to, in a way, distort or stop the painful signals from going into the limb or to the foot. So spinal cord stimulation is another treatment that we can offer our patients. We first do a trial, and the trial usually lasts for about 7 to 10 days. We want to identify the right patient, obviously. So we want to make sure that when we do this trial, which is a temporary placement of this device outside the patient's back, and look at the outcome for 7 to 10 days. And if our patient gets consistent results, where their pain is significantly improved during that trial phase, then we schedule them to do an implant. And the goal with the implant is that the implant will help alleviate the patient's pain continually so that they're not suffering and they're able to ultimately have a better quality of life.
And Dr. Demian, you also have, as well as yourself, Dr. George, you have specialized training in ultrasound. Can you expand upon that subject?
So a lot of joints or kind of peripheral areas that may cause our patients pain are easily accessible without any ultrasound guidance. But sometimes there are deeper joints or deeper nerves or deeper pain generators that are around sensitive areas that you would want to use ultrasound guidance to make sure that the medication gets to where it needs to go safely. Injections and ultrasound guidance for injections allows us to target deeper areas or deeper joints that are not easily accessible without guidance. And those are procedures typically done within the office, and a lot of times can provide immediate relief that would just not only help our patients feel better, but also diagnose their problems.
Anything to add, Dr. George?
To add on to what Pavli said, I think ultrasound guidance is a great option for our patients because it allows us to provide this treatment injection on site. So, unlike some of the procedures we do, we have to schedule them in a fluoro suite or under X-ray guidance. So we'd have to schedule them later, while an ultrasound guided injection can be done on site while the patient's there. Maybe they may need to be scheduled a couple of days later, but there is the ability to schedule them sooner. The other positive about the ultrasound is that it's safe. So X-rays, to some extent, although albeit very rare, we do worry about X-ray exposure. Ultrasound, on the other hand, is a safe device, and we don't have to worry about any X-ray exposure to the patient. And as Pavli already stated, there is that added benefit of visual guidance, which improves accuracy. And we were able to accurately guide that needle to the target site, whether it be a joint or whether it be a peripheral nerve, to either identify or even treat the underlying condition.
So in summary, I would say that we have a large toolbox in which to treat painful conditions in a non-operative way. I would add that with great pleasure and great honor, we are the first 3 physiatrists in the 50-year history of University Orthopaedics. And it is quite an honor and a distinction. But we have an obligation and a commitment to excellence consistent with the traditions of this institution. And we work very closely with all the other physicians. Here at UOA, we're one-stop shopping for orthopedics and pain management. We are commonly referred patients from the various departments within University Orthopaedics, which includes the spine department that would send us patients that have conditions involving from the cervical spine through the lumbar spine, or from the hip or knee surgeons or shoulder specialists to treat their patients non-operatively. We may get trauma patients that have nerve injuries, for which we diagnose through electromyography or through ultrasound. And we may be able to do injections involving those either joints or to do nerve blocks under guidance. So therefore, if you have a painful orthopedic condition, we are looking forward to treating you and encourage you to reach out to us at uoanj.com.